Dear colleagues, it's indeed an honor, a great pleasure to have this talk today and to discuss with you the new advances with regards to brain imaging techniques in the context of movement disorders. I'm very thankful to the organizers of this Congress, to the chairs, and I hope you will find this lecture of interest. I will have about 20-25 minutes, and therefore I decided to focus mostly on Parkinson's disease and atypical Parkinsonism. First of all, these are the disclosures. I received several speaking honoraria and sponsorship, but none of them related to this lecture. So why is important to address this topic of brain imaging? Indeed, these examinations, these brain investigations are important to support a clinical diagnosis in our routine clinical practice. And this is quite important to provide a prognostic assessment for adequate patient counseling and for patient-tailored therapeutic approaches, potentially also disease-modifying options and clinical trials. So reaching a most exact diagnosis as possible is indeed a value for our patients. The main problem we have to face from the very, very beginning is that all these brain imaging studies are compared to the clinical evaluations. And therefore, we still lack in most of the studies anatomopathological confirmation of the diagnosis. I'm showing you here a very interesting study by the group of Hughes and his colleagues, where they compared, they evaluated 143 cases of subjects, patients with Parkinsonism, and they compare the anatomopathological findings, post-mortem diagnosis here on the left, and the clinical diagnosis. And as you can see, there was quite a mismatch between the two. And this was performed in Specialist Movement Disorder Service, Movement Disorder Center. And colleagues were able to reach a quite high sensitivity and specificity for idiopathic Parkinson's disease, but for other Parkinsonism like multisystem atrophy, progressive supranuclear palsy, and corticobasal degeneration, and vascular Parkinsonism, the positive predictive value was quite low. Two are the main evaluations that we can perform in our patients, either MRIs or PET and SPECT investigations. Some basic principles of MRI techniques. Basically, this is related to a magnetic field where nuclei line up with their magnetic moments, either in parallel or anti-parallel configurations. And then by applying a relaxation time, either recovery or dephasing, we can investigate the content of different tissues. So basically, we are either applying some T1 relaxation, T2, so recovery or dephasing, and this would allow different images to be performed. In the past decades, there has been many more sequences, technical advances that significantly improve the quality of these images. Blood oxygen level dependent functional MRIs, diffuser tension imaging, diffuser spectral imaging, and so on. We will also discuss some of them in some future next slides. With regards to PET and SPECT imaging, it's a different methods, completely different methods. The main difference is related to the fact that for this investigation, we have to inject a radioactive compound, a ligand that is radioactive, and but after the injections, after a certain time from the injections, allowed some brain imaging investigations. There are two possible studies. One is called PET, positron emission tomography, and the other one is SPECT, single photon emission computed tomography. The difference is related to the kind of machines, but also the ligands that we can use. PET tracers emit positrons that travel 1 to 3 millimeter before annihilating with electrons and therefore causing 2 gamma photons that can be emitted in opposite directions. And this is the kind of the image of the collimator that is capturing the two gamma photons, and by computing the delay, can reconstruct the images. SPECT tracer instead emit gamma radiations and single gamma radiation, so the quality of the image is less than PET investigations. It's also important to address the utility of such neuroimaging biomarkers. In a recent study, Withwell and colleagues, a study published in 2017, they proposed this 5-level theoretical construct to classify the different neuroimaging biomarkers, either MRI or PET or SPECT biomarkers. So they can be just research tools, but they can be useful also to support the clinical diagnosis at an individual level. There can be also biomarkers that could be useful for early disease stages, or, and that's level 4 and level 5, they can be either supportive for pathological diagnosis or definitive biomarkers. For 4 and 5, we, in the context of Parkinsonism, we don't have any available yet. This study was a review study on PSP patients. And here you can see listed in the central column the many biomarkers that they were able to identify for progressive supranuclear palsy patients with Richardson syndrome. And on the right side for the other variants of PSP patients. There are quite a few. I would not have the time to go in details for all of them, but I would like to draw your attention here on the only two ones that were supportive for early clinical diagnosis. Actually, as I previously anticipated, none of them was reached such an accuracy to be considered as supportive of pathological diagnosis or definitive biomarkers. So among the one that could be used for early clinical diagnosis, we have the midbrain pons area ratio and glucose PET. Talking about the first one, which is this, the midbrain pons area ratio, it's just one of the many that can be identified using MRI techniques in progressive supranuclear palsy. Going back to the left side, one is the Hummingbird sign, which is an atrophy of the mesencephalus. Then there is the Morning Glory Mickey Mouse sign here pointed by the white arrow. And then there are several measurements of the midbrain anteroposterior diameter here and the superior and middle cerebellar pedunculi. With regards to glucose PET, please focus on the PSP line. Here we can identify in these patients several areas of increase or decrease metabolic consumption. Glucose PET is a PET study using as a radioligand glucose, which is radioactive glucose that can be uptaken by the cell, cannot be used. So after the injection and a waiting time of 10 to 15 minutes, when we are performing PET images, we can clearly identify some areas of increase glucose uptake or decrease glucose uptake. And here on the right side in the figures is in red and blue. Red is increased and blue is decreased. For PSP patients, as I mentioned before, we can clearly distinguish some areas, the one in blue here, that are evocative of a reduced metabolic activity in mid-frontal cortex and the brainstem in particular, and several other areas of increased metabolic consumption, which are the thalamus, parietal, and frontal cortices. Going back to the top of this list, we can see what are the changes in Parkinson patients in a very early stage, Hoenyar stage 1, where we have an increased metabolic activity in the putamen, possibly a compensatory activity in this area. When we go to stage 2 and 3 of Hoenyar, so moderate Parkinson's disease, we still can see this increase putamen uptake, but also involves the thalamus and the cerebellum, so possibly a compensatory activity of the cerebellum over putaminal activity loss, and decrease metabolism in the frontal and parietal areas, which are supporting finding for a Parkinson's disease. Multisystem atrophy is also important as is quite a dramatic atypical Parkinsonism, and it's quite important to distinguish it from Parkinson's disease, and it's difficult, especially in very early stages. In this case, instead, we have a reduced putaminal glucose uptake, which is opposite than the picture we can see in Parkinson's disease. And this was quite an early finding and quite reliable also in my experience. The last Parkinsonism is corticobasal degeneration, where we have a reduced metabolic consumption in frontal, temporal, and parietal areas, which usually match the clinical side, match the clinical presentation, which is involving the contralateral hemibody with some Parkinson's signs like kind of rigidity, bradykinesia, but also apraxia and early limb syndrome. These were studies performed by David Idegroup group for the past decades, really providing more and more evidence of the great value of glucose PET in the differential diagnosis, also in a very early stage, and also in a single subject case in the context of Parkinson's disease and Parkinsonism. They were also able to identify specific patterns whose expression suggests it's evocative of Parkinson's disease or other Parkinsonism. Still one problem remains, which is the comparison, the correlation with anatomopathological findings, so post-mortem findings. This is a case report by Smith and colleagues using a novel PET ligand, which is called AV1451, which is binding protein tau. This is quite important. So the research advances in this field are quite relevant and quite important, because they try to bridge, to link in vivo evaluations with what is the true anatomopathological findings, which, for example, in PSP, it's protein tau depositions. Here there is a comparison in panel A and B between what is so-called PET of protein tau and glucose PET. The surprising results is that when comparing these PET images, in vivo images, with post-mortem finding, the authors could not really see any correlation between PET imaging with a new ligand targeting protein tau and the tau deposits in the neurites. On the contrary, deposits of tau pathology correlated to the one of different areas, different brain areas, substantia nigra, pallidus, dorsal midbrain, and putamen correlated with glucose PET uptake. So possibly glucose PET was even more sensitive to capture the derangement of the activity of these areas due to tau pathology. With regards to multisystem atrophy, we have already discussed the reduction in putaminal glucose uptake. This matches quite well with MRI findings, also at 1.5 Tesla. These are MRI findings, two T2 images. Here you can see, especially in MSA-P patients, so Parkinsonian type, that there is a loss of an atrophy of the putamen, especially the tail, which matches with the glucose PET finding, and also this rim hyperintense outer margin of the putamen. The other phenotype of MSA multisystem atrophy is a cerebellar type. In this figure, in these patients, usually we see a cerebellar atrophy, this hot cross-band sign, and also hyperintense middle cerebellar pedunculi. In these patients, it will be also prominent a reduction of the glucose uptake in the cerebellum. great advances in recent time, the past years, has been derived from different data analysis approaches. Combining, for example, in this study, they combine, for example, glucose PET, T1 weighted images, and susceptible weighted images, and they use a deep learning algorithm and define some multivariate, they call it multivariate radiomics models, that by combining these images, we're able to reach a 95-96% accuracy in discriminating Parkinson's disease from multi-system atrophy at an early disease stage. Again, the diagnosis was based on clinical investigations in these studies. Other advances in new sequences derived from MRI in recent time, targeting the nigrosome or free water corrected fractional isotropy or neuromelanin sensitive MRIs. In particular, the last one was probably the one most intensively studied in the context of Parkinson's disease and typical Parkinsonism. Here I'm showing you some images of neuromelanin sensitive magnetic resonance imaging. The first two are healthy subjects, and the middle ones are Parkinson's patients. But still, as you can see in the right side, there's quite an overlap between healthy patients here in blue and Parkinson's patients. We also use neuromelanin sensitive magnetic resonance imaging in a cohort of about 20 Parkinson's patients and compare it with healthy subjects. And the two main measurements are either the assessment of the volume of the nigra or the contrast ratio. It's interesting to notice that these measurements, both of them correlate with the dot binding values at the striatal level in Parkinson's patients. And here you can see the strong correlations between the volume of the nigra and the contrast measurements of neuromelanin sensitive MRIs with the dot binding values. What is the dot binding? It's a measurement that we can perform with SPECT or PET investigations and ligands that bind dopamine reuptake transporters. Indeed, the synaptic cleft, dopaminergic synaptic cleft, was one of the most intensively studied, also from a molecular imaging point of view. Here I'm showing you the nigrostriatal projections, top substantia nigra and bottom in the striatum. And there are several ligands, for example, the ethyltetrabenazide, who is targeting the vesicular monoamine transporters. We mentioned already the dopamine reuptake transporter ligands, such as methylphenidate or ioflupane, which is commercially known as DATSCAN. And then we also have fluorodopa PET, which is investigating dopamine decarboxylase activity in the synaptic cleft. At the postsynaptic level, we also have quite valuable ligands like raclopride or falipride targeting D2, D3 receptors. Difference between the two, as you can see here, is the radioactive atom, which is carbon or fluoride. This makes a difference in terms of the kinetics and of the radioligand. Raclopride has an annihilation time of minutes, falipride of hours. The DATSCAN still remains the currently most useful biomarker for Parkinson's disease. Here I'm showing you an image of one Parkinson patient here with ONR stage 1 compared to a healthy subject. Let's focus on the healthy subject first. Here you see the striatum, which is kind of this comma-shaped. This is the dot of the comma is a caudated head, and then the putamen tail, quite symmetric. And indeed, the symmetry is the first thing that's is going to be lost in Parkinson's patients, with one side more dopamine depleted than the contralateral one. And this matches the clinical presentation. Also, the putamen is more involved in an earlier stage of the disease than the caudated head, the caudated nucleus. In ONR stage 2, the changes, the reduction in dopamine reuptake transporters tend to become more homogeneous and bilateral. And in late stages, ONR stage 4, we have to increase the background unspecific dot binding measurements to still capture the position of the striatum. These measurements, FP-SIT or DASCAN measurements, proved also of some value in addressing disease progression. Those are 4 images of the same Parkinson patients, young chap of 41 years old. This is as the time of the diagnosis. Please notice again the asymmetry and the involvement of the putamen more than the choroidal head. And again, 1 year after, 2 years after, and 7.5 years after. The dot binding measurements correlate well with akinetic ridges signs in Parkinson's disease. There is also a correspondence between the hemisphere with less dopamine binding values and the contralateral and the clinical presentation of the symptoms, so the contralateral side. This is just a snapshot. There are several of our printout of a case report of one of my patients recently investigated in the clinic. There are several softwares for an automatic evaluation of DAT-scan measurements. And here you can see on the left side the caudate, left and right, and on the right side the putamen values in this subject with still a clear asymmetry, mostly again involving the putamen, then the caudate, and the threshold values of healthy subjects. Going back to the studies, this is another interesting study of David Alderberg with glucose PET, correlating glucose PET, which of course is here in the middle and right part of the slide. On the left side, there is the progression, disease progression in clinical with the UPDRS motor score, baseline 2 years and 4 years. Follow up the DAT-scan decline over time, and they were able to identify with longitudinal FDG PET evaluation the progression of these metabolic changes with an involvement of the increased metabolic consumption in the cerebellum, STN, and paracentral area, and GPI, and progressive loss of glucose uptake in frontal and parietal areas. This is quite an important study because it shows that FDG PET is valuable also, it's comparable to DAT-scan in providing information for an early diagnosis and monitoring disease progression in these patients. What comes next from research is, and this has been intense research of the group of Barone, Karolinska Institute, is having available PET ligands targeting the DOT. And this is one of the most recently developed, which is called PE2I. And here you can clearly compare the two images. The PET images are much more defined. You can clearly distinguish the caudate head from the putamen in these two patients. And on the right side, you see the close correlation between the DAT-scan in healthy subjects in green, but also in Parkinson patients, correlation between DAT-scan and this new PET ligand. This studies can be also, of course, combined. This is a very interesting study, more on the research side, evaluating Parkinson patients with 3 different ligands. So the methylphenidate targeting dopamine retractase transporters, tetrabenazide targeting vesicular monoamine transporters, and fluorodopa targeting decarboxylase activity in the same patient. So this it's indeed a great valuable results of great value because they can address the dopaminergic activity at different levels. And the comparison between these results showed that DOT binding values fit an exponential decay higher in the first 5 years. The annual percentage loss of striatal DOT does not parallel clinical worsening of symptoms measured with UPDRS part 3, and this suggests compensatory mechanism, for example, from the cerebellum, and we have addressed it several times in previous slides, but also that the mechanism underlying PD initiation and progression are probably different, and this is of great value for disease-modifying strategies. There are many new ligands coming up, now tested for research, and we hope that some of them will be also of clinical utility for a better diagnosis, for a more accurate diagnosis of our patients, possibly with anatomopathological strong correlations. More is yet to come, and we really hope for better resources to improve the diagnosis of our patients for more tailored and patient-specific therapies. This was my last slide. I would like to thank many people that worked with me in the past years, and of course, I would like to thank you for your attention.